So that clearly shows everything. So most of my job is done because you have very nicely explained how the pathogenesis of IBD happens, how the barrier function get destroyed, and how these innate and adaptive immune cells, they get activated, and there's a dysregulation, disbalance between these two cells, and finally leading to the release of various cytokines that cause further damage in the barrier function and in the pathogenesis. So how this mechanism is taken up by the pharma company, and they have made one drug which can work on this mechanism and give the beneficial effect. So I am starting my presentation. So as already explained by Mahapatra sir, that there is a various genetic factor and environmental factor that cause damage to the mucosa, and that leads to release of cytokines, cytokine receptor activation, and finally leads to the JAK-STAT signal transduction. So JAK-STAT signal is the final pathway where the cells, they are activated and they release various cytokines by protein synthesis. So why we are targeting JAK-STAT signaling? There are many pathways. Why we are not targeting those? Why we are targeting JAK-STAT signaling? So JAKs actually play a role in regulating cellular proliferation, differentiation, and immune cell functions. So T cells, they are involved in the proliferation of these cells and final release of all these inflammatory cytokines. So JAK-STAT is the major signaling cascade downstream from cytokine and growth factors. So JAK family consists of JAK1, JAK2, and JAK3. And there's a STAT family which has 7 transcription factors. So JAK serve to transduce signal from cytokine receptor. So when the cytokine, they act on the T cells, then JAK pathway get activated, and that leads to release of cytokines. So JAK inhibitors interfere with JAK-STAT signaling. They compete with ATP for binding of the kinase domain of JAKs and inhibit JAK1, JAK2, JAK3. So JAK inhibitors are used effectively in other chronic inflammatory conditions like RA and psoriasis. They have widely used, and that's why this company, they have got this idea that why not use in the IBD. So JAK inhibition is a potential therapeutic target in ulcerative colitis because JAK1 and JAK3 is involved in transduction process of IL-2R and IL-6R receptors. So, and this molecule, Tofacitinib, is basically a partial inhibitor of JAK1 and JAK3. It is not a complete inhibitor. It's just a partial inhibitor of JAK1 and JAK3. So JAK signaling pathways you see in ulcerative colitis, that here you can say all these interleukins, IL-2, IL-7, IL-10, interferon gamma, then IL-6, IL-12, they all act through the JAK-STAT pathway. And this JAK-STAT pathway, it activates the nuclear mechanism to synthesize more protein, and that's why they release various cytokines. So this Tofacitinib, they acts on JAK2 and JAK3, JAK1, JAKs, they do not act on other, and that leads to the inhibition of this JAK-STAT signaling. So treatment goals, again, our treatment goals for the patient of ulcerative colitis is first is to control, that is induce the remission, and second is to maintain that remission. That is the goal. That is the basic of treatment of ulcerative colitis. This slide already explained by Mahapatra sir that what are the therapeutic options we have today. And in this armamentarium, we have added this JAK inhibitors. At present, it is basically approved for the treatment in ulcerative colitis, but the Crohn's disease data are coming up. They are not still available with us, but the ulcerative colitis, it is now approved. So if you see the current treatment option, is we start our treatment from mild, Then moderate in severe disease, depending upon the severity, we choose the drug. But the problem is that, so why we are looking for JAK inhibitors? JAK inhibitors because whatever the current treatment we are giving, there is a problem because only 25 to 40% patients, this group of patients, they remain primary or secondary non-responder to conventional therapy. Even after giving the best therapy, they are keep on relapsing. They are some are steroid dependent. Even they are on azathioprine, even on these biologicals. There is a quite significant proportion of the patients who are not responding, and it is around 20. And we are facing day to day. Every gastroenterologist is facing the problem that our treatment is very much limited. We are not happy with the kind of molecules currently we are having. They are not meeting the need. They are not, they are not giving a good quality of life to the patients. So there is a gap. There is a gap for the therapy, and that's why research is going on to find out what are the other options where we can add in the treatment of ulcerative colitis, and one of these is the JAK inhibitors. So JAK kinase inhibitor, see that is tofacitinib is a JAK inhibitor. It binds to the JAK enzyme and thus down-regulates the production of pro-inflammatory cytokine and thus reduces inflammation. It is used. The beauty of this molecule is that it can be used not only for induction but also for the maintenance, just like mesalamine. And it is not like a steroid where we cannot use for remission. It is not like azathioprine where we cannot use for induction. So that's why in May 2018, for moderate to severe UC patients were failed to conventional therapy. So nowadays, it is not the first line drug. This is approved only in those patients who are failed to conventional treatment, right? Like steroids, like mesalamine preparations, azathioprine. All these are failed. In those patients only, it is currently recommended. And in that group also, only the moderate to severe ulcerative colitis. Why? Why? Because the design of the study was like this. But because for the ethical clearance, you need to plan the study where you see that there is a gap, treatment gap. So that's why this group is selected. But as soon as we get more data on this, we will see that some studies are also looking into the mild cases also, or the initial treatment also. But right now, because of the ethical reason, because of the design of the study, it is only for the moderate to severe ulcerative colitis patients. The beauty is that it's a very fast acting and it's a short half-life, very short half-life, and that's why it's ideal for dose testing. There are good trials on this, and they have in one trial they have assessed, that is 598 patients in Octave 1 induction trial, and Octave 2 induction trial they have included 541 patients. And these patients are those patients who had treatment failure with conventional therapy. They were randomized to 4:1 ratio, and dose was 10 milligram twice daily or placebo for 8 weeks. And they observed the patient at 8 weeks, and there is an improvement in the appearance of lining of their clone at 8 weeks. What extent we will see. So they found that at 8 weeks, 18% of patients taking 10 milligram of tofacitinib twice daily achieved remissions, compared to 6% taking placebo. Similarly, at 2 weeks, tofacitinib, 30% of patients taking 10 milligram tofacitinib twice daily had improvement in the intestinal lining, and 14% in placebo. So you will be surprised that just 18%, only 18% patients, they have achieved remission. Only 13% patients, they have improved. Such a low, but actually it is not low, because we are treating moderate to severe ulcerative colitis patients who are already failed on other therapy. So this figure is encouraging. It is not disappointing. So if you see the clinical response overall at 8 weeks is 58%. It's not achieved. We have not achieved clinical remission, but there is a response at 58 weeks. So for maintenance therapy, Octave Sustain 2 trial, they have found that 34.3% patients who are on 5 milligram and 40.6% they are on 10 milligram, they maintain the remission at 1 year. So it's quite encouraging data that one third of the patient they are maintaining the steroid-free remission, which is quite good, quite encouraging. So overall, if you see that this molecule has definitely has future, and I'm hopeful that when other few more, we are also waiting for the few data, but right now this ad we have something to offer these patients who are not responding to our conventional therapy. So thank you very much for your kind attention. I close my presentation on this, and we will take the question at the end of the presentation. Thank you very much. And this is my center. We have started a new center, Live Gastro Center at Begerhata. I invite all of you to please come to the center and have a look on that. Thank you very much.